So my clinical pattern is trigger finger, which is also known as tendovaginitis. It's a painful clicking or popping at the A1 pulley of the finger during a finger flexion or extension, and it's caused by inflammation that can lead to the narrowing of the pulley system. And this can also lead to nodule formation in some patients in the later stages. As far as the prevalence, there's about 28 cases per 100,000 people per year, with a 2.6% risk with the general population, and it increases to 10% in patients with diabetes, but that's more associated with the length of diabetes and not glycemic control. And then with age, it peaks with ages less than 8 years old, which is 0.2% of the population, which mainly affects the thumb with bilateral symptoms. And in those ages 40 to 60, which is 2.6%, it affects mainly the thumb and the ring finger, but it's unilateral. So for children, bilateral and affects the thumb. For older adults, it's unilateral, affects the thumb and the ring finger. And then as for the gender, it affects more women than men. And then for the outcome measure, you could either use the stages of stenosing tenosynovitis, SST, or the DASH, which is the disabilities, the arm, shoulder, hand outcome measure. With the mechanism injury, it can be caused by repetitive finger movements, local trauma, or extensive gripping with hand flexion. Aggravating factors include prolonged finger flexion. Easing factors would be ice or heat, ultrasound, massage, and stretching. And with the 24-hour pattern, it can be stiff or there could be swelling in the morning. And you could also wake up with the locked finger that loosens throughout the day. As far as precautions and contraindications for exam and treatment, forceful movements beyond the restriction attempted by the patient can lead to triggering movements that can be very painful. So if their finger is kind of locked in flexion, you try to move them out of that, it can actually cause the triggering in the finger, and that can be really painful when the pulley moves. For the physical examination, for observation, there can be stiffness or swelling at the MCP joint. The finger can also be locked into flexion if you're seeing them in the more later stages of trigger finger. With active movement testing, there can be limited and painful finger extension. Less common would be limited finger flexion, also painful. With passive movement testing, it would be limited and painful finger extension. For resisted testing, there could be pain and possible weakness with the MMT of the flexor digitorum profundus and superficialis, and it may not be possible to do if their finger is locked into flexion. With accessory motion testing, there could be possible hypomobility of the PIP, the MCP, the DIP, and CMC joint of any of the affected finger. With the neuroscreen, you probably wouldn't do it because there is no neurological symptoms. And for special tests, there is no specific actual test, but there is like an outcome measure thing you could use called the open and close hand 10 times. And you can actually use that to see if there's the trigger of the finger happens. As far as palpation, you could see tenderness over the A1 pulley, and then there could also be a palpable notch on the palmar side of the MCP joint. For the differential diagnosis, specifically for the locking of the digits, it could be a dislocation, Dupuytren's contracture, focal dystonia, flexor tendon or sheath tumor, or a sesamoid bone disorder. Specifically for pain at the MCP joint, at the thumb, it could be de Quervain's tenosynovitis or a UCL injury, or it could also be an MCP joint sprain, extensor apparatus injury, or MCP OA. For diagnostic imaging, an ultrasound or MRI could confirm the findings as well. And then it would be time to refer back to a physician if you saw any of these signs or symptoms. If the joint was hot or inflamed, that would need immediate treatment. That could be a sign of an infection. If there's a nodule, it's not painful and it's slow growing, that could be a sign of a tumor. If there's limited movement, pain, major swelling, that could be a sign of a dislocation or a fracture. And then if there's bruising, swelling, pain, limited movement, that could be a sign of a soft tissue injury. So any of those, you might want to refer back to a physician. For pharmacological interventions, NSAIDs and corticosteroid injections have been seen to be the most common treatments. And as far as surgical indicators or options, if the conservative methods fail, then surgical methods are then used. There's the first one is called percutaneous trigger finger release, and that's where the A1 pulley is stretched out and it's held in an extended position, and then the needle is used to incise the pulley. And then the surgery, the A1 pulley is exposed on the palmar side. The pulley is then divided, and then usually for thumb cases in children, surgical release is actually the traditional treatment. And yeah, that is the clinical pattern for trigger finger.